Hi, everyone. I am Dr. Pallav Mehta. I am a breast cancer medical oncologist at MD Anderson Cancer Center at Cooper. I also head up the Department of Integrative Oncology. And today we'll be talking about integrative health in breast cancer and how it relates to the work in disparities that's being done. So we'll begin first with my story. So what you see there is a cup of a drink that my grandmother used to make every morning. So I emigrated to the United States when I was about 6 years old. And in our apartment in New York City, the four of us would sleep in the bedroom, and my grandmother would sleep in the living room. And I distinctly remember coming outside every morning, and she would have this ready for me, this concoction, which was milk, molasses, crushed almonds that she actually used a mortar and pestle for, and turmeric. And I would drink this every morning, and she told me that it would give me strength and it would clean my blood. So now we flash forward to the story of one of my patients. So this is actually a patient of mine from a couple of years ago, Melissa. She was 37 years old when she first noticed a sudden red swollen breast at 34 weeks into her first pregnancy. And she was clearly diagnosed with a stage 3 inflammatory breast cancer. She was induced and delivered at 36 weeks, and then went through the rigors of treatment, as you see there, 4 months of chemotherapy, a double mastectomy, lymph node dissection, radiation. She was then found to have a mutation in a gene that leads to breast cancer, the BRCA1 gene. So she chose to have her ovaries removed. She started treatment with an anti-estrogen medication, and then underwent a reconstructive surgery that did not go well. So we move forward 1 year, and what we see is Melissa, who is alive, is depressed, she's anxious, she's irritable from the menopause and the other treatments. Her hair and nails have not grown back right. She does not feel bonded with her baby. She has neuropathy from chemotherapy. The appearance of her right chest is what she describes as a gunshot wound to the chest. She has gained 25 pounds. She has joint pains and hot flashes from the endocrine therapy that I'm giving her. Her heart function has actually dropped, and she is in bankruptcy and marriage counseling. And this is all completely true. This is Melissa's PET scan. So for anyone who reads PET scans, you can see here, this is a clean PET scan. She is cancer-free, but the question is she healthy? So when thinking about health, which I do a lot as a breast oncologist and as an integrative physician, we go back to the World Health Organization, the world's authority on health. And in their first constitution in June of 1946, they defined health as a state of complete physical, emotional, and spiritual well-being, and not merely the absence of disease or infirmity. So this is a philosophy that I think many of us use to treat our patients. Hippocrates, the father of medicine, said that it's more important to know what sort of person has a disease than to know what sort of disease a person has. And that leads to my philosophy on treatment of cancer, which is that I don't treat cancer, I treat people. So why is it on the rise? We are doing lots more tests on people, a lot more CAT scans and PET scans and MRIs, and we're finding things that we otherwise wouldn't find. The population is getting older, and cancer is a disease of older people. We now are curing a lot more people because of our advances in treatment. And particularly in breast cancer, we are seeing a lot more women who are alive with metastatic stage 4 breast cancer who otherwise would not have been 20, 30 years ago. So this leads to the idea of survivorship. So survivorship starts at diagnosis and continues for the rest of a patient's life. The current estimates for cancer survivors by the year 2025 are almost 20 million. So this is going to place a significant burden on the healthcare economics and society of this country. Survivorship deals with the immediate and long-term consequences of breast cancer diagnosis and treatment on physical, psychosocial, financial health. The financial toxicity is a term that's being used much more these days as the expenses of cancer therapy have risen significantly. So about 20 years ago, the National Institutes of Health established the department that is now known as the National Center for Complementary and Integrative Health, which states that integrative medicine combines mainstream medical therapies and complementary therapies for which there is high quality scientific evidence of safety and effectiveness. We know in the world of breast cancer that upwards of 80 to 85% of women use some form of integrative therapy. And here's just some examples. We have things like vitamins and minerals and herbal supplements, but also nutrition is an integrative therapy. There are mind-body practices, as you see here. But again, if you look at the bottom, there exercise. Just plain exercise is considered an integrative therapy. And then there are other treatments that have less clinical evidence, but are certainly practiced by millions worldwide. So there actually, in my opinion, is a global epidemic that's happening right now. It's raging throughout the world. It's killing scores of people, many of them with underlying medical conditions, many of whom have cancer, but it's actually not COVID-19. It's misinformation in healthcare. This is a topic that probably 10 or 15 years ago or 20 years ago really wasn't as prevalent in breast cancer or in cancer in general, as information just wasn't as readily available. Today, anyone on their phone within 5 minutes can go down a rabbit hole of information related to their disease and often end up with information that is detrimental to their outcomes. Researchers at Yale had noted an almost 6 times greater risk of death from breast cancer in patients who only used complementary and integrative therapies instead of conventional therapies. Interestingly, mostly these were younger, white, and higher socioeconomic status women. The caution here is, be careful. Many of our patients hear about all of these. We have heard about all of these, from alkaline diets to coffee enemas to various dietary plans to vitamins that don't really exist. And in my opinion, we have to know a little bit about these so that we can properly inform our patients. And beware of those who invent a fake crisis and then profess to have the solution. We often see patients who have conditions that don't really exist: adrenal fatigue, parasitic infections. Simply being able to test the level of something does not mean we know what to do with the result when we get it. And remember, just because it was done thousands of years ago does not mean that it makes sense today or that it's even useful. So that brings us to the current guidelines from the NCCN. Here are the basic guidelines around lifestyle, which recommend a diet rich in plant-based foods, limiting processed and red meat, refined sugar, limiting alcohol, and maintaining a healthy BMI. So, as most physicians will tell you, in my medical training, after college, 4 years of medical school, 3 years of residency, and 3 years of a combined hematology-oncology fellowship, that sliver that you see there is how much I actually learned about nutrition and exercise. As physicians, I think we learn a lot about disease. We learn very little about health and how to be healthy. And I think it's incumbent upon us, particularly in today's age, to make sure that we do take the time to learn. So this is currently what is known as the New American Plate. This replaced the food pyramid, and I'm not so sure they did a great job marketing because most of us really aren't aware. But the New American Plate was developed by the American Institute for Cancer Research about 10 years ago, and its basic tenets are portion and proportion. This is primarily plant-based foods and non-starchy vegetables. So on the left, you see there the older recommendations. You see the mashed potatoes, butter, and a large portion of red meat. On the right, we see that the vegetables make up the larger portion of the plate. And here's the quick summary of the foods that the American Institute of Cancer Research feels fight cancer. On their website, they have some wonderful information about each and every one and why they feel that the various phytonutrients are useful as cancer fighters. The World Health Organization labeled processed meats a Category 1 carcinogen a few years back. So this is definitely something we want to limit. And sugar, as we know, is really not good for us. Refined sugar intake has increased substantially over the last 30 to 50 years, but certainly over the last 200 years. And there are several detrimental impacts to our breast cancer patients. There have been connections to depression, anxiety, and even cognitive dysfunction in our older patients. Weight gain, it's almost impossible for a postmenopausal woman to lose weight if her insulin levels are going up and down. And there appears to be a connection potentially with cancer risk due to the upregulation of IGF-1 or insulin growth factor 1. This is a condition known as Laron syndrome, which most people have not heard of. It's a rare condition. Only about 5,000 people or so in the world have it. And it leads to a malfunction in the receptor for growth hormone that actually limits and essentially eliminates IGF-1 production. So what's interesting about this population of people, as you can see here, they are very short in stature. They actually live a normal life expectancy of about 75 to 80 years. And although their BMI is high, there's almost no incidence of diabetes. But what's interesting is while the incidence of cancer in the world is about 1 in 3, there's almost no instances of cancer in patients with Laron syndrome. Alcohol, as we know, has detrimental effects at higher levels, but what we see in our breast cancer population is actually a detrimental impact even at lower levels. So the UK Million Women study, this was primarily white women, Caucasian women, demonstrated that for every serving increase per day, which is about 10 to 12 grams, there was a 12% increased risk of breast cancer. Similarly, analysis from the AMBER Consortium, which looked at over 5,000 African-American women with breast cancer, found that for Black women with breast cancer, that more than 7 servings a week increased recurrence by 15% and more than 14 servings by 33%. 14 servings a week sounds like a lot, but in actuality, many of us go home after work, we're tired, and we have a drink. Sometimes that drink involves a couple of shots of gin. Sometimes it involves 2 small glasses of wine. Both of these, if you do it every night, 14 servings a week for women is considered heavy alcohol use. And as you see here, for African-American women, increased the breast cancer recurrence risk by 33%. This is a question that we get a lot as physicians, organic. Should we eat organic? Should we not? This list of 12 foods is published by the Environmental Working Group, known as the Dirty Dozen. It's the list of 12 crops that have the highest pesticide content, or herbicide content to be specific. So if our patients are going to go organic, these are the ones that sort of will give you the best bang for their buck. For the first time, there actually is data to show that an organic diet may actually be beneficial. There was a French study published in JAMA a couple of years ago that looked at 70,000 people, mostly women, mostly young women, the average age was 44, reporting their intake of organic foods based on 4 different quartiles. And what they found is that women who ate organic had a 25% reduction in cancer risk from the highest intake group to the lowest. So why organic? One of the reasons points to the issue of GMOs. So GMOs are genetically modified organisms. And GMOs actually have some real benefit around the world as they increase crop yield and harvest. But they are, in this country, many crops are modified genetically to be resistant to herbicides. So they greatly simplify weed management. The industrial farm can spray the entire field with these herbicides and not worry that their crop will die. The problem is the crop then absorbs that herbicide. And as we know, the herbicides can be toxic. The International Agency on the Research of Cancer, again, has deemed glyphosate, which is the ingredient in the most popular herbicide in the country, as a probable human carcinogen, a category 2A, which means we are spraying our fields with a probable carcinogen. In July of 2020, just last month, a couple months ago, Bayer agreed to settle 125,000 claims for over $10 billion that its weed killer caused cancer. So what is the impact on Black America? Well, we know that diet-related disparities are prevalent. The MedStar Institute showed that Black women over the age of 65 had significantly lower intake of fruits and vegetables, nuts and legumes, and fiber than their white counterparts, 20% higher amounts of added sugar, and interestingly, only 8% of Blacks lived in a census tract. A census tract is a small part of a county that includes anywhere from about 1,500 to about 6,000 people. 8% of Blacks lived in a census tract with a grocery store versus 31% of whites. And even more interestingly, for every additional grocery store, Blacks were 32% more likely to consume produce. Whites only 11% more likely. So just the simple addition of a grocery store to a neighborhood can have a vast impact on the health of that neighborhood. Convenience stores, interestingly, were much more prevalent in Black neighborhoods, and convenience stores often have low nutrition foods. The Cardia study was a 30-year prospective cohort of over 5,000 Black and white men and women looking at diet, exercise, and smoking. And what they found is that these three factors, socioeconomic, psychosocial, and neighborhood factors, played the biggest role in the differences in behavior and diet. Of those, socioeconomics was by far the largest impact. About 55% of the impact appeared to be socioeconomic between Black and white women. Socioeconomic factors in this study were divided into education, household income, net worth, etc. So that brings us to obesity. This is known as a disease of civilization, and we are not the only ones facing this. Developing countries around the world are now dealing with the issue of both malnutrition and obesity. There are a myriad of connections between obesity and cancer, as you see here, from tissue hypoxia to insulin resistance to inflammation and others, and much of this is still being ironed out. But really, what is obese? So this does vary somewhat country by country, but in the United States, currently, after some changes that were made about 15 to 20 years ago, these are the cutoffs. So a BMI of 25 to 30. So a BMI, of course, is weight in kilograms over height in meters squared. 25 to 30 is overweight. 30 and above is obese. 40 and above is considered severely obese. In medicine, we use the term morbidly obese, which in this clinical setting really doesn't exist, but morbidly obese would essentially be severely obese. We can see here that 40% of the population of this country is actually considered obese, and almost 10% are severely obese. This is actually from the CDC. So if we look state by state, the top figure is non-Hispanic Black adults, and the bottom figure is white adults. You can see the vast difference in rates of obesity. So the red states are not politically red. This is red based on over 35% of the population is obese. So in non-Hispanic Black adults, in fact, the majority of states, we're seeing that. So 44% of non-Hispanic Black women over 18 were considered obese, and 31% were overweight, compared with 29 and 28% respectively for white women. Cancer survivors, as we know, are at the highest risk of weight gain. We often put young women into menopause. We limit their activity because they're fatigued and they have pains. We give them chemotherapy that changes their taste, neuropathy that limits their ability to exercise, muscle loss, bone loss, not to mention all the emotional impact. I'll mention quickly about supplements. We use natural products for lots of things, but remember, they are not FDA regulated. These labels, our patients will often ask us, what supplements are safe. There's obviously hundreds and hundreds of brands. These three labels that you see here, which are the National Science Foundation, the US Pharmacopeia, and Consumer Labs, if you see these labels on your supplements, then you know that the supplement company has voluntarily asked for their product to be tested by these independent organizations, and they verify that the dose that you see on the bottle is the dose that's in the bottle. Plus, they verify that it's free of contaminants like heavy metals. And lest we think that supplements are not something that should be used in our modern society, this woman is, her name is Yu Tu. She's a scientist. She's a Chinese scientist who in her late 80s, a few years ago, won the Nobel Prize in medicine. She was part of the scientific team that was charged by Chairman Mao during the Vietnam War to figure out a treatment for malaria. Chairman Mao, who the Chinese were backing the North Vietnamese, and the soldiers were getting killed in the jungles from malaria. So she translated this 1700-year-old textbook and realized that the wormwood plant produced a chemical that seemed to help with a febrile illness, which she thought to be malaria. So she was able to figure out how to get this out of the wormwood plant and ultimately developed artemisinin, which today is still considered the most effective therapy for Plasmodium falciparum in the world. And she won the Nobel Prize for it, and she has neither PhD nor MD. On the other side is the VITAL trial, which looked at 20,000 men and women and looking at supplementation with vitamin D and omega-3 fatty acids. At the first interim analysis, which was recently published, did not show a benefit at 5 years median follow-up. I think most of us did not feel that 5 years would be sufficient to see a benefit, but we do await further follow-up on this trial. This is a photo of the state of fitness in our society today. I was a personal trainer before I was a physician, and I can tell you often I would see clients taking the elevator, the 6 flights up to get to the Stairmaster. There's no intervention that has as much data, A to Z, as exercise. So physical activity, in 1997, the AICR estimated that 30 to 40% of cancers could be prevented with diminishing body mass index and increasing activity, and then went further to say 50,000 cases of breast cancer were possibly a result of both inactivity and its short and long-term consequences. And its role in cancer, well, we know it diminishes obesity by increasing muscle to fat ratio, inflammation, stress. We don't want to underestimate how looking and feeling more confident for our patients is relevant. Again, as I said, for our breast cancer patients who lose their hair, who gain weight, who are then asked to go back to normal, often it's difficult. So exercise brings back a sense of identity for them. Unfortunately, what many of us practice in our jobs is the sitting disease, which in 2010, the American Cancer Society coined the term and published results of a study of over 125,000 volunteers and found that women who sat more than 6 hours a day versus their counterparts who sat less than 3 were 94, so almost twice as likely to die from cancer and heart disease. And this impact was relevant even in the women who exercised. So for our patients, we have these simple tips. I think many of us often talk about exercise, but the current recommendations are 150 minutes of moderate intensity exercise. You can talk, but you can't sing is the definition of moderate intensity. And for encouragement, we want to let patients know that Rome wasn't built in a day. This is a slow progress. And once patients do make progress, they often will continue these habits. It takes 4 to 6 weeks to form a habit. We want to make sure for women that we really talk about all 3 of these types of exercise. So there's cardiovascular exercise, which is something I think most of us know about, but we do not want to forget resistance exercise for our breast cancer patients. Many of them are, because of menopause, have diminished bone density because of these medications, have diminished bone density. They lose muscle because of inactivity. Resistance exercise really helps with all of that. And we want to instill the message that there really are no excuses, and you can find 5 minutes in a day. It does not require going to a gym for an hour every single day. Yoga is actually, for a lot of our patients, a complete exercise. Depending on how it's done, there's resistance benefits, there's flexibility benefits, there's cardiovascular benefits, and we know the data in breast cancer is clear that it fights fatigue and encourages deeper breathing and improves sleep and anxiety and depression and all of the above. Even has been shown to diminish pain from post-mastectomy syndromes. And finally, stress. This is a broad term. Stress, as John Steinbeck said, a sad soul can kill you quicker, far quicker than a germ. So what is it? It's a state of mental tension that's caused by anxiety and worry in work, family, and relationships. It is a common symptom in our patients diagnosed and treated for cancer, some who even have PTSD, post-traumatic stress disorder-like symptoms. And this really does lead to bad behaviors. Mice who were exposed to chronic stress, chronic stress was that confining them to a small cage for long periods of time had a 30-fold higher rate of metastasis of breast cancer cells than the non-stressed mice. So how do we manage stress? Well, we talked about exercise and eating well, which does manage it. We know that different types of stress our patients have: physical, emotional, spiritual, financial, relationship stress. We do not want to forget hormonal stress for many of our patients. Menopause, obviously this is a funny cartoon, but for some of our patients, menopause and its impact is not so funny. They have a difficult time navigating their work and their relationships, and on top of the fact that they already are worried about cancer recurrence. So what strategies can be used? There are several, and we would ask our patients to seek out legitimate sources of these approaches, from oncology massage to acupuncture to mindfulness, to guided imagery, and progressive muscle relaxation, among many. So thank you for having me. As we know, integrative therapies really should not be looked at as distinct from conventional therapy, that we manage our patients with breast cancer with chemotherapy and radiation and surgery and hormonal therapy. But as I said earlier, we're treating people, not cancer. And when we're treating people, we look at them through the lens of humanity and the lives that they lead. And so integrative therapies can help them get back to those lives. So thank you.